Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Zia from the MMK Educational Initiative platform. Today we will discuss the chest wall and diaphragm. In first lecture we will discuss the chest wall and diaphragm anatomy, and in second lecture we will discuss the physiology. The objective of today's lecture is, at the end of the lecture, students should be able to know the basics of the anatomy. Student can describe the components of the thoracic cage and their articulations. He can be able to list the muscles involved in inspiration and expiration, and also the origin, insertion and nerve supply of the muscles. Describe the origin, insertion and nerve supply of the diaphragm. And in the second lecture, which is of the physiology, basic respiratory control centers, respiratory movements and mechanisms of breathing will be discussed. Thoracic cage. Thoracic cage is conical in shape as shown in the diagram. It has two apertures. One is superiorly, which is called the thoracic outlet, which is narrow, open and continuous with the neck structures. Inferiorly, the aperture is wide but it is closed by the diaphragm. Thoracic cage is formed of sternum and costal cartilages anteriorly, 12 pairs of ribs laterally on each side, and 12 thoracic vertebrae posteriorly. In thoracic cage, there are three different types of joints. One is the sternocostal joint, other is the costochondral joint, and then the costovertebral joint. As far as sternocostal joint is concerned, the first costal cartilage articulate with the manubrium sterni by a primary cartilaginous joint, while from the second to seventh cartilages, the articulation with the sternum is by the synovial joint. The costochondral joint is the joint formed between the costal cartilage and the ribs, and the type of joint is the cartilaginous one, while the costovertebral joint is the joint between the heads of the rib and the thoracic vertebral bodies, and these are the plain synovial joints. Thoracic cage. This is the table which is summarizing the different types of joint, the movement possible and the general comments. Costovertebral joint is the synovial joint and there is no movement at this joint, while the sternocostal joint is synovial except for the first rib joint, which is the cartilaginous one. This sternocostal joint is mobile except for the first rib, which is fixed. That is the joint where the joint is the cartilaginous one, there is no mobility possible, while at the synovial joint movement is possible. Often the synovial joint has susceptibility to motion. Then the costochondral joint, it is the cartilaginous type of joint and there is no movement possible at cartilaginous joint. Then the manubrium sterni joint, it is the fibrocartilaginous joint. Small angular movement may be possible. And then the xiphisternal joint, which is also a fibrocartilaginous joint and there is no significant movement possible at this joint. This is the another diagram which is showing the thoracic cage and different joints in the thoracic cage, which we already discussed, that are the costovertebral joint, which is the plain synovial joint, sternocostal joint, which is also a plain synovial joint, and the costochondral joint, which is the cartilaginous joint. Respiratory movements or mechanics of respiration. Two types of movements are responsible in the respiratory process. One is the movement of the diaphragm and second is the movement of ribs. Movement of diaphragm can be in the downward or upward direction. When the diaphragm contracts in the process of inspiration, it leads to the descent of the diaphragm and increases the vertical diameter of the thoracic cavity. And then the expiration, which is the passive process, the diaphragm relaxes and ascent of the diaphragm occurs to the original position and the air moves outside the lungs. Second type of movement is the movement of the rib. Movement of rib can be of two types. One is the pump handle movement and the other is the bucket handle movement. In these movements, there is increase in the anterior-posterior diameter and lateral diameter of the thoracic cavity respectively. Pump handle movement leads to the elevation of the ribs in a way that sternum moves superiorly and anteriorly, and just like a handle of a water pump, and increases the anterior-posterior diameter of the thoracic cavity. In the bucket handle movement, there is the elevation of ribs by the elevation of the lateral shaft of the ribs, and the lateral diameter of the thoracic cavity is increased. Both these movements together lead to increase in the thoracic cavity diameter and the movement of the air inside the lungs. Diaphragm. Diaphragm is a musculotendinous partition between the thoracic and the abdominal cavities. It is convex towards the thoracic side and concave towards the abdominal cavity side. It is attached to sternum, costal cartilages, 12th rib and lumbar vertebra. The fibers of the diaphragm converge to join and inserted into the central tendon of diaphragm. Nerve supply is via the phrenic nerve, which has a nerve root of C3, C4 and C5. The phrenic nerve penetrates the diaphragm and innervates it from the abdominal surface. The action of the diaphragm can be contraction, which leads to the descent of the diaphragm and increases the vertical diameter of the thoracic cavity in inspiration. Origin of the diaphragm. Diaphragm arises from the costal cartilage, from the vertebral bodies and from the sternal surface. The costal cartilage, lower 6 costal cartilages is the point of origin, and the vertebral bodies, upper 3 lumbar vertebra, right and left cross of the diaphragm and arcuate ligaments are attached, and on the sternal side, the Zephyr process of the sternum is the point of origin. These are the two diagrams which are showing the anterior view and the posterior view of the thoracic cage, showing the attachments of the diaphragm. When we study the detail of the diaphragm, we can divide it into a central tendon, right and left crura, and right and left dome of the diaphragm. As you can clearly notice in this diagram that there is the right dome of the diaphragm, left dome of the diaphragm, central tendon of the diaphragm having the opening for the inferior vena cava, and the right cross and left cross of the diaphragm having the opening for the esophagus and the vadai, and the median arcuate ligament and medial arcuate ligament having the opening for the abdominal aorta. Crura and arcuate ligaments of diaphragm. The right cross of the diaphragm arises from the sides of body of the number 1, number 2 and number 3 vertebra and intervertebral disc. The left cross arises from the sides of the body of the number 1 and 2 vertebra and intervertebral disc. The lateral to the crura, the diaphragm arises from the medial and lateral arcuate ligaments. The medial arcuate ligament extends from the side of the body of the satin lumbar vertebra to the tip of the transverse process of the first lumbar vertebra. The lateral arcuate ligament extends from the tip of the transverse process of the first lumbar vertebra to the lower border of the 12th rib. The medial border of the two crura are connected by the median arcuate ligament, which crosses over the anterior surface of the aorta. It should be differentiated from the medial arcuate ligament, which is towards the lateral side of the median arcuate ligament on the both sides, and lateral to the medial arcuate ligament is the lateral arcuate ligament on both sides. Functions of the diaphragm. Diaphragm function as a muscle of inspiration. It is the main muscle of inspiration, and on contraction the diaphragm pulls its central tendon down and increases the vertical diameter of the thoracic cavity. Muscles of the abdominal straining. It assists in the contraction of the anterior abdominal wall muscle in raising the intra-abdominal pressure for maturation, defecation and parturition. It also acts as a weightlifting muscle. It also acts as the thoraco-abdominal pump. The descent of the diaphragm decreases the intrathoracic pressure and increases the intra-abdominal pressure. This compresses the blood in the inferior vena cava and forces it upward into the right atrium of the heart. Next is the openings in the diaphragm. The diaphragm has three main openings. You should memorize these openings by T8, 10 and 12. The T8 opening is the caval opening. It is present at the thoracic 8th vertebral level in the central tendon of the diaphragm, and the structure passing through this opening include the inferior vena cava and branches of the right phrenic nerve. The second opening is the esophageal opening. It is present at the thoracic 10th vertebral level in the right crus of the diaphragm, and the structure passing through the esophageal opening is esophagus, right and left vagus nerve, esophageal branches of the left gastric vessels and lymphatics. And finally the aortic opening. It is present at the level of the thoracic 12th vertebra between the crura. The contents are aorta, thoracic duct and the azygous vein. Nerve supply of the diaphragm. Diaphragm has motor nerve supply from the right and left phrenic nerve, which has a root value of C3, C4 and C5. Sensory nerve supply. The parietal pleura and peritoneum covering the central surface of the diaphragm are supplied from the phrenic nerve, and the periphery of the diaphragm is supplied from the lower 6 intercostal nerves. Now we will discuss briefly about the other muscles of the rib cage. External intercostal muscle. These are attached from the lower border of the rib above to the upper border of the rib below. Direction of the fibers are downward, forward and medially. It is supplied by the intercostal nerves, and the action is it functions as a rib elevators and helpful in the inspiratory process. Rest of the intercostal muscle, which involve the internal intercostal muscle, innermost intercostal muscle, subcostal muscle and the transversus thoracis muscle. The direction of fiber is the upward, backward and medial, and they are supplied by the internal intercostal nerves, ventral rami from the T1 to T11. And the main function of these muscles are they act as a rib depressors as against to the external intercostal muscles, which are the rib elevators. Accessory muscles of the respiration, which are only involved during the forced inspiration. These are the muscles attaching the cervical vertebrae to the first and the second ribs and into the scalene muscles, and secondly the group of muscles attaching the thoracic cage to the upper limb, which are the pectoralis major muscle. First of all, scalene muscles. Scalene muscles can be scalenus anterior, scalenus medius and scalenus posterior. They arise from cervical vertebrae and inserted into the first and second ribs. Their action is to elevate the first and second rib during the inspiration, forced inspiration. Then the pectoralis major muscle. It arises from the sternum and the costal cartilages and inserted into the humerus, upper part. And the action is increases the anteroposterior diameter of the thoracic cavity when the arm is fixed. Then the muscles of expiration. They act only during the forced expiration, because normally the expiration is a passive process, and it includes the rib depressors, which are the internal intercostal, innermost intercostal, subcostal and transversus thoracis muscle, as discussed in the previous slides. Muscles of the anterior abdominal wall. Anterior abdominal wall is formed of 3 layers of muscle fiber: external oblique, internal oblique and transversus abdominis muscle. These muscle fibers run in different directions to increase the strength of the anterior abdominal wall. The 3 muscle forms a sheath in which 4th muscle, rectus abdominis, lies. Muscles are attached to the sternum, costal cartilages and ribs, and in the downside they are attached with the hip bones. The aponeurosis of the 3 muscles on both sides fuse in the midline to form the linea alba. These muscles action during the forced expiration by compressing the abdominal viscera to help in the ascent of the diaphragm. The nerve supply is from the lower 5 intercostal nerve from T7 to T11, subcostal nerve T12 and the first lumbar nerve L1. This is the another diagram which is showing the external oblique outer layer, internal oblique middle layer and the transversus abdominis innermost layer. The fiber direction of the external oblique is downward, forward and medially, and in the case of internal oblique it is upward, backward and medially. In transversus abdominis muscle the fibers are transverse, and then the rectus abdominis, which is covered by the anterior and posterior rectus sheath, and the direction of fiber is vertical. This is the table summarizing the respiratory muscle. External intercostal muscle. The fibers of the external intercostal muscle move in a downward and medial direction from the lower border of the rib above to the upper border of the rib below. It is supplied by the intercostal nerves, and its action is elevation of the ribs in inspiration. Then the scalene muscle. It is of 3 types: scalenus anterior, scalenus medius and scalenus posterior. They arise from the cervical vertebrae and inserted into the first and second ribs, and their function is to elevate the first and second rib during inspiration. Pectoralis major muscle. It arises from the sternum and the costal cartilages and inserted into the humerus. Their function is to increase the anteroposterior diameter of the thoracic cavity when the arm is fixed in inspiration. Then the rectus abdominis muscle. It arises from the sternum, costal cartilages and ribs and hip bones. It is innervated by the intercostal nerves T7 to T11 and subcostal nerve T12 and the first lumbar nerve. The action of the rectus abdominis muscle is the compression of the abdominal viscera to help in ascent of the diaphragm. Expiratory muscles are the rib depressors. Internal intercostal muscle, innermost intercostal muscle and subcostal muscle and transversus thoracis muscle. They are supplied by the intercostal nerves via the ventral rami of the T1 to T11, and their direction of movement is upward and medially. Then the anterior abdominal wall muscle. These are all rib depressors. These include the external oblique outer layer, internal oblique middle layer and transversus abdominal inner layer, and then the rectus abdominis muscle. Finally, the clinical notes regarding diaphragm. First of all, hiccup. What is hiccup? It is the involuntary spasmodic contraction of diaphragm at accompanied by the approximation of portal rods and closure of the glottis resulting from the gastric irritation of vagus nerve. It may, however, be a symptom of disease such as the pleurisy, peritonitis, pericarditis, or uremia. Other is paralysis of the diaphragm. If the phrenic nerve gets injured in the neck by crushing or sectioning of the phrenic nerve, it can lead to the paralysis of the single dome of diaphragm. And the penetrating injuries of the diaphragm, the important point to remember is that any penetrating wound to the chest below the level of nipples should be suspected of causing the damage to the diaphragm until proved otherwise, because the arching domes of the diaphragm can reach the level of the fifth rib and the right dome can reach a still higher level. So we should be vigilant in any penetrating injury of the chest or the upper abdomen that it can damage the diaphragm. Thank you very much. Any question?